Next, we're gonna talk with about CVS and CHH, which is kind of a new thing on the horizon. And Lynn?
So we are going to hear from a wonderful speaker, Dr. Thangam Venkatesan. She's a professor of medicine. She was at Medical College of Wisconsin. She recently relocated to Ohio, and she really is an expert in cyclic vomiting syndrome, as well as cannabinoid hyperemesis syndrome, and that's what she's going to speak about. And then after, we're going to have a patient talk about cyclic vomiting syndrome, and that's James O'Reilly. So we'll hear his story.
Good morning. Thank you for having me today. And I would like to thank the IFFGD for addressing this really important issue. I will be talking to you today about cyclic vomiting syndrome and cannabinoid hyperemesis syndrome, what a physician should know. These are my disclosures. Cyclic vomiting syndrome has actually been around for several years, and in fact, centuries. This is one of the first few reports of CVS by a pediatrician. And this was first reported by this doctor by name Samuel G., who said that there were 14 children who had fitful or recurrent vomiting. These reports first appeared in the St. Bart's Hospital Reports Journal in 1882. It is also curious that there are several important prominent persons who had CVS, and CVS can actually afflict patients of all ages and socioeconomic strata. This is a picture of Charles Darwin, and this is actually a letter that he wrote to some officers, and he apparently was going to host some of these people, but he was unable to even come down to dinner because he had this violent episode of vomiting that lasted. And so this was a letter that he wrote to these 3 officers from the Beagle. And so CVS can really affect a lot of people. Why is CVS important? Now, CVS is common. Even though it's thought to be rare, it is mostly because it's either underdiagnosed or misdiagnosed. The prevalence of CVS in adults, based on a population-based study, is around 2%. The prevalence in children is also similar. CVS is also very expensive. The total cost of CVS is about $400 million from just inpatient hospitalizations over 2 years. And this was done based on what we call an NES database, which looks at a national database of inpatient hospitalizations. And so you can clearly tell that there is a huge impact due to CVS. What about diagnosing CVS? Unfortunately, CVS does not have any biomarkers or blood tests to diagnose it, and we rely on something called the Rome criteria. So we have had 2 iterations of the Rome criteria. We now have what is called the Rome 4 criteria, which is a set of clinical criteria to diagnose CVS. So essentially, if you have stereotypical episodes of vomiting, which are acute in onset, lasting less than a week, and you have 3 or more discrete episodes in the prior year, and you are either completely normal in between episodes or have mild symptoms, you could have CVS. Obviously, your physician would conduct a few tests, such as like an upper endoscopy or a CT scan, to make sure that there are no other GI conditions that could be causing the vomiting. And if these criteria are fulfilled for the last 12 months with symptom onset at least 6 months before diagnosis, then one can establish this diagnosis of CVS. Again, there are some minor differences between Rome 3 and Rome 4 criteria that are not particularly important, but it is important to note that patients with CVS can have mild symptoms in between episodes. And now moving on to the clinical features. The clinical features are very characteristic. In general, CVS consists of 4 phases that have been characterized by Dr. Fleischer, who is sort of like the grandfather of CVS. You have the inter-episodic phase where patients are typically either in normal health or can have mild symptoms. You have the prodromal phase where patients can experience multiple symptoms such as nausea, abdominal pain, diarrhea, an impending sense of doom, etc. This is then followed by the emetic phase, where patients will have nausea, vomiting, retching, and multiple autonomic symptoms such as diarrhea. Now, this emetic phase can last from a few hours to many days in patients and can be quite variable. And then you have the recovery phase. The importance of knowing these various phases is that abortive medications can be administered during the prodromal phase to try and abort or stop an episode. What about hot showers? The hot shower bathing pattern is something that is talked about a lot with regards to CVS and cannabis use. Essentially, patients with CVS will take multiple hot showers or baths during a CVS episode. And sometimes there are some patients who can even run out of hot water and check themselves into a hotel to have ready access to hot water. While the hot water bathing pattern has been associated very strongly with cannabis use, it's important to note that almost half the patients of CVS without cannabis also will report this hot water bathing pattern. What about the management of CVS? The management of CVS we finally published the guidelines on the management of CVS in adults last year. And so essentially, once a diagnosis of CVS is made, a physician should try and help the patient identify and avoid triggers. Good sleep hygiene is important. Stress management is also important. Patients with CVS can have several comorbid conditions such as anxiety or depression, cannabis use, autonomic dysfunction, and migraine. And these also need to be treated, and referrals need to be made. And one needs to assess the severity of CVS before determining what kind of treatment the patient needs. And essentially, this is an arbitrary definition of the severity of CVS. And in general, mild CVS is noted when patients have less than 4 episodes a year, when the episodes are very brief, lasting less than 2 days. There's a quick recovery from episodes, and patients in general have no ED visits or hospitalizations. And CVS is considered as moderate to severe when there are multiple episodes or greater than 4 episodes a year. The episodes generally tend to be longer, and there's a long recovery from episodes, and there are multiple ED visits and hospitalizations. In general, abortive treatment is offered to all patients. Abortive treatment generally consists of triptans or intranasal sumatriptan, antiemetics like ondansetron, phenothiazine, and antihistaminics. And in addition to abortive treatment, prophylactic therapy should be offered to patients with moderate to severe CVS. Now, this is a consensus of the recommendations for the treatment of CVS. In general, if you have moderate to severe CVS, your physician should be prescribing or offering you medications like tricyclic antidepressants or amitriptyline, which is considered first-line prophylactic medication. Unfortunately, there are no randomized controlled trials in CVS, and the quality of evidence is low, but be as it may, this is effective therapy. Other alternative medications for CVS include topiramate as prophylaxis and also aprepitant. Aprepitant or Emin is a newer medication and can be used for both prophylaxis and aborting CVS episodes. However, the cost can be quite prohibitive, as many insurance companies may not cover this. There are other anti-epileptic agents such as zonisamide and such that can be offered to patients. There are mitochondrial supplements, including CoQ10 and riboflavin as well, which can be used. And as I mentioned earlier, the abortive medications such as sumatriptan or intranasally is very helpful. I think most people would use ondansetron, and then aprepitant is also a newer medication that can be used to abort symptoms of a CVS episode. Very often, we will have patients take all of these medications together. It is also very important that physicians screen and treat for comorbid conditions like anxiety and depression, migraine headaches, sleep disorders, autonomic dysfunction, and substance use. And finally, a note about other techniques. Complementary therapies like meditation, relaxation, and biofeedback can be very helpful, particularly with stress management and improving the overall quality of life of CVS patients. And one pointer here that it is very, very important to take the rescue medications as early as possible possible in a CVS episode to abort symptoms. Now, switching gears a little bit, what about cannabis? Cannabis in CVS is very common, and almost 40% of patients with cyclic vomiting syndrome use cannabis. And so I think we need to discuss this a little bit. What about cannabinoid hyperemesis syndrome? CHS is a condition that is similar to CVS. So it is characterized for the same stereotypical episodic vomiting that we see in CVS. However, there is an association with prolonged excessive cannabis use, and there should be relief of vomiting episodes by sustained cessation of cannabis use. And so while the Rome criteria doesn't quite define what sustained cessation means, most experts would recommend that you need to be off cannabis for at least 6 months to a year to see if there is any change in your symptoms. Again, CHS can be associated with this pathological hot water bathing behavior that we discussed. And before talking a little more about the risks and possible benefits of cannabinoids or cannabis, we need to know what are cannabinoids. So cannabinoids are compounds that have an affinity of what we call cannabinoid receptors that we have in the body. These are densely distributed in various areas in the body, including the brain and the nausea and vomiting and the vomiting center in the brain. There are 3 types of cannabinoids. We have phytocannabinoids and endocannabinoids and synthetic cannabinoids. Phytocannabinoids are derived from plants. Endocannabinoids are actually synthesized in humans. So we produce substances like marijuana in our body. What about phytocannabinoids? Typically, the marijuana cannabis that is consumed in the market is derived from 2 plant species, Cannabis sativa and less often Cannabis indica. And while they can contain many compounds, the most important compounds that are found or of importance are tetrahydrocannabinol or THC and cannabinoid or CBD. And I think there is a lot of interest in CBD, and the reason for that is that it is not psychoactive. So it does not give you the high that THC gives. And it also actually is not technically a cannabinoid because it acts on 5-HT1A receptors and not the cannabinoid receptors. Cannabis concentrates can be particularly harmful. The risks of physical dependence and addiction increase with exposure to high concentrations of THC. Higher concentrations of THC can actually produce anxiety, agitation, paranoia, and psychosis. And it is thought that it has a biphasic effect. So low doses of cannabis may be okay, but higher doses may result in hyperemesis. This is an important slide that I would like both patients and physicians to focus on. And this looks actually at the percentage of THC and CBD in cannabis samples that were seized by the DEA. And here you have in the 1990s. So in 1995, the concentration of THC was around 4%. And as you can see, there is a dramatic increase, and we are now at around 15%. And this is just the percentage of THC that you would see, say, in a joint. If you look at cannabis concentrate, because of the way cannabis products are produced these days, the amount of THC or the concentration of THC in these products can be very high. And it can be upwards of 70%, at times even greater than 80%. So it's really important to know what you are using and what the concentration of THC would be. For example, dabbers can inhale an entire amount in a single breath, and this delivers really large amounts of THC to the body very quickly. In contrast, the THC, as I said, in a marijuana, say joint or a cigarette, is 15%. But again, this is so much higher than what it was in the 90s. And so I think it's a very different beast that we have out there today. So we really need to know, is this good or bad, right? And what are the problems with cannabis? Unfortunately, this is a study that looks at ED-related ED-related visits, and this is related to marijuana tourism in Colorado. And so this is around the time that marijuana got legalized in Colorado. And if you look at out-of-state patients, a lot of patients actually go to Colorado, and this is part of the marijuana tourism. And so there was a significant increase in ED visits by out-of-state residents. And so I think it's important to understand this a little better. Is this because people are using more cannabis, or is it because CVS is being recognized more is not clear. And now we also looked at cyclic vomiting presentations following marijuana liberalization in Colorado, and the ED visits clearly increased and doubled over this time. Again, it's hard to understand if these were patients previously diagnosed with gastroenteritis. Was there an increased recognition of this vomiting pattern by ED physicians who didn't really know much about CVS before marijuana came around? Or is it because of increased reporting of cannabis use by patients because it's been legalized? Again, it's probably a combination of all of these factors. And so we looked at patterns of cannabis use in patients with CVS. This was a study that we did. And as you can see, this part of the pie, around 60% of patients don't use cannabis at all. And 22% of patients, so 1 in 5 patients, reported that they use cannabis more than 4 times a week. And in general, these are the chronic users or the chronic heavy users, daily or near daily cannabis use, which can be problematic. However, when you ask them about their cannabis use, the patients actually reported that it improved their symptoms. So this actually is a figure that looks at the percentage improvement in symptoms with cannabis use. And a significant proportion of patients reported that there was a reduction in vomiting episodes, severity of vomiting, abdominal pain, appetite, and some people even said that they were able to avoid ED visits and hospitalizations, and they were able to continue working and also studying. Again, it is important to note that this is a patient report. And coming back to the other study I spoke about, we did look at some of our patients. And then when we looked at patients who were cannabis users who abstained from cannabis for at least a month, there was only 1 patient who reported resolution of symptoms following cannabis cessation, but this patient actually subsequently resumed his use with higher CBD content and remained symptom-free. And so the rest of them really said that they didn't find any major improvement. But however, I think a longer follow-up is needed because the patients in the study had been off cannabis for only a month. And it's really important to be off cannabis for a longer period of time. And we looked at the role of cannabis in cyclic vomiting syndrome and CHS, and we actually looked at 105 individual cases and 25 case series. And when we looked at this is an important slide. Though these cases said that these patients had CHS, there was no significant follow-up, and there was actually a lack of detail in these studies in the literature. So I think there are some limitations. For example, if you look at how many people were followed for greater than 4 weeks following abstinence, only a small proportion of these case reports and case series had this particular follow-up. And then if you look at the number of people who actually met Rome criteria, again, I want to point out that these cases and case series were reported before the Rome criteria. And so there was only a very small proportion, 14 and 20%, who actually met diagnostic criteria for CHS. So it's really not clear if all these people who were reported as having CHS in the literature really had cannabinoid hyperemesis syndrome. And so I think it's a little difficult to know. We do not have enough good understanding. I think it's important to know that the cannabis products that are out there can be very potent. There are also studies showing that some people are genetically predisposed to the adverse effects from cannabis. And I spoke about endocannabinoids in the body. And endocannabinoids are compounds actually that are very important. They are marijuana-like substances that we produce in the body and are very important in the regulation of nausea and vomiting. So there could be an endocannabinoid deficiency. And finally, as I said, the potency of cannabis products is also a problem. So I think it is really important to keep these things in mind. There is certainly a big debate that rages about whether it's good or bad. We need more funding and research. In the meantime, the takeaway point is if you're going to use cannabis, it's probably best not to use cannabis if you have cyclic vomiting. And if you are, certainly occasional use may be okay, but near daily or chronic use is really going to be detrimental. And finally, I'd like to acknowledge all of these people. Some of these are my mentors. This is B. Lee, who is sort of the guru in pediatric CVS. Some of the other researchers who've done studies with me. and my nursing team who really take care of these patients, and it would not be possible without them to do this work that I do. And Kathleen Adams is actually the former president and founder of the Cyclic Vomiting Syndrome Association. Again, thank you for listening.
Hi, so my name is James O'Reilly. I'm 50 years old. I was born in Dublin, Ireland, and I deal with cyclic vomiting syndrome. Had it as a child. My mom would say that I would get sick to the yellow of my stomach, and that I wouldn't get better until I get all of that bile and yellow acid out of my stomach. And so I remember as a child here and there being sick, really sick at times, but didn't really pay much attention to it. Always kind of had an inner feeling that something was a little different, but that's okay. Different is good. So anyway, as a young child, then I moved to the States as an 8-year-old and didn't really get sick much then. Then when I was a teenager, and certainly when I go back to visit my cousins in Ireland, I would get sick for 2 or 3 days. Figured I just wasn't a drinker like they are, and was able to just, deal with it, and figured I'm not a drinker. So throughout high school and college, no issues, played hockey all the time, played sports, worked outside in the heat at a golf course. None of those were really problems. Again, every now and then it would happen where I'd go out partying with friends and, feel miserable for a day or two. Then when I was 28, it started to happen. We were at a party, we were out late, got back, 5 in the morning, and woke up the next day at 2 in the afternoon and was sick for 2 days, and it was really bad. And then that kind of started it where it was happening 3-4 times a year. And again, I wasn't drinking, so I didn't think that was it. Knew something wasn't right. And probably after about 2 or 3 years of going to the ER, I try and ride it out at home. I would get very dehydrated, vomit blood because I'd rip my esophagus, dehydrated, just feeling the worst. I mean, the worst. I've I've shattered my elbow. That wasn't even half as bad as what I go through with cyclic vomiting syndrome. Anyway, went to the ER a bunch of times. No one could figure it out. No tests to prove what it is. Everything was coming back negative. We still knew something wasn't right. So my ex-wife, probably after about 2 years of this, and one morning at 4 a.m, the doctor saying, "We know what's wrong with him. He vomits. Everybody vomits." Well, that wasn't acceptable to her. She went to the office. Within 15 minutes, she found cyclic vomiting syndrome, and literally word for word, I was going through what that described. So I was probably diagnosed at around 28, 29, and went to a bunch of doctors, got that confirmed. I went out to see Dr. Fleischer in Missouri. He kind of confirmed that was it. I believe I was patient 432, if I remember correctly. Anyway, he made me feel, boy, the relief of just knowing what's wrong with you helps, because, like G.I. Joe said, knowing is half the battle. And if you know what's going on, then maybe you can deal with it a little bit more. So it got to the point where I was having anywhere from 20 episodes to 40 episodes in a year. My worst years were 38 episodes, 38 hospitalizations one year, 40 the next, and then like 38 the next after that. And so those were some tough years, needless to say. And I was able to get through all of that. So I still tried to play hockey when I could. It wasn't, when I'm sick, I'm really sick. Like I said, ripped esophagus, Mallory-Weiss tear, vomiting acid, vomiting bile. It doesn't go away until I get that stuff out of my stomach. Nothing digests. Anyway, so when I usually go to the hospital now, I walk into the ER, "James, come on in, room number 11. The IV team's been called. The pharmacy's getting the O'Reilly cocktail together." And so that really helps. It helps in the wear and tear of my body. It helps just in the recovery afterwards. Getting plenty of fluids and plenty of meds is just tremendous relief, both physically and also mentally. The comfort of the fact that I know that I can walk into a hospital, that A, they know me, and B, that they're taking me serious about this. Because I've been in many situations where doctors are telling me, oh, there's nothing wrong with you, or, you know, are you drinking? I once had a 6'4" nurse ask me if I was a heroin addict. I weigh comfortably over 250 pounds. I'm definitely not a heroin addict. So anyway, it's just a lot of misinformation out there. I'm finding that more and more of the younger doctors are certainly aware of it and have a better understanding of what's going on. I've certainly run across enough doctors, both in the ER and other doctors, telling me, oh, it's, you know, because of marijuana use, or it's because, you know, it's all in your head. Just people that either don't understand, don't want to understand. Just that I don't get. I don't understand how doctors don't want to learn more about things that people don't know about. Anyway, so for the last 22 years as an adult, I've been dealing with it. This year, I've already been in the hospital, I will say about 15 times. No, sorry, 15 episodes. I've probably written 3 or 4 of them out at home. I'm not going to do that anymore. I had one last week, and it took me 3 days after I stopped vomiting to recover. And so just get to the hospital, get the right stuff done, get the right, you know, meds in me, and then my, you know, 20 to 30 hours of vomiting then is, you know, once I get out of the hospital, I'm in great shape. I feel rested. I'm well hydrated. That definitely doesn't happen at home. It got to the point where I got a port in my chest because I just couldn't find veins in my arms anymore. That was the best thing that I've done. It's just been phenomenal. It's again another relief. I'm certainly very, very lucky that I can go to a hospital, like I said, and walk in and they take care of me. They know me. I know all the nurses on the floors. So, you know, we've become brothers and sisters to some degree, you know, talk about family and this and that. So that is tremendous. Like I said, getting back to the illness, if I don't get that acid or that yellow bile out of my stomach, then it just continues on. I don't feel well. As for the future, I understand what I have. I think in the last couple of months, I've realized that probably the biggest part for me with cyclic vomiting syndrome is what brings it on is that if I don't eat, I'm in the swimming pool business, and it's, you know, you're just fully in gear, galloping all the time, getting stuff done in the summertime. And so I'm finding that if I skip a lunch and I don't eat until, you know, late afternoon, then the next day I tend to have episodes. And those ones aren't half as bad as some of the other ones, but I've just kind of noticed that correlation, and that's a problem. So, and then also for the daily meds I take amitriptyline. I was on a really high dose. I gained a lot of weight. I've lowered it. I've dropped maybe 15 pounds. So that's been a big help. Maybe lower it again. I'm at 50 milligrams right now. I take 1 milligram of Ativan every night just to help sleep. Again, with my shattered elbow, I have a lot of problems sleeping the last couple of years. That at least knocks me out for 5 or 6 hours, and that's a tremendous help. If I'm rested, then I'm feeling pretty good. And then I take Prevacet 30 milligrams every day just for the antacid and the acid production. And if I miss a couple of days there, I'll start to feel not well. So yeah, that's pretty much it. As far as my life goes, so I run and I own my own swimming pool construction and service company. We're up in Westchester County, north of New York City. Days can be long, the hours can be long. The stress is certainly there if you let it get to you. I don't feel stress anymore. If you have cyclic vomiting syndrome, your dirty pool isn't as important sometimes. And I also let all my clients know what I have and what I deal with. I also have some good guys that I've worked with for 15 or 20 years, 25 years. that I can depend on, and we all know my situation, and we all act accordingly off of that. I have a 11-year-old son, and I can tell you that that's what gets me through every single episode, every single day. That I just want to see him on the other side of that episode. I want to see him get big, I see him to be healthy, and I want him to have a great life, and I want to be a part of it. And if it wasn't for him, certainly I probably wouldn't be here sitting here talking to you guys. It's like I said, being sick as often as I had, I can, and not that I ever would, but I can certainly understand why people would just want to get it all over with. And being as miserable as that, I feel like I'm lucky because I only get sick for 30, 40 hours, and then I'm done with it, and then I'm, back to being my normal self. Certainly I've heard tons of stories and spoken to tons of people that have it and they're nauseous for 15, 20, 30 days at a time. And I just don't know how they do that. I get it anyway. So unfortunately, over the years, I've heard of some people that just didn't want to deal with it anymore, and they took that way out. But you got to be strong, got to hang in there. I got to say, and I know what a miserable day is all about, and today's not one of them. And that's how I go. That's just how I get through it all. Tomorrow's gonna be better, no doubt about it, if I am sick. And if today's a great day. Doesn't matter what happens, today's a great day. I've got my health, I can stand up, so it's all good on that end. But I think the biggest advice or words of encouragement are tomorrow's another day. You'll be able to get through it. You're certainly strong enough. You've fought through it this long. There's a certain toughness in a lot of us that you can. My feeling is that I can handle anything thrown at me. If I'm dealing with this, I can handle anything else that's being thrown with me. And I think that that's just what you have to do. Today's not a good day. Tomorrow's going to be better. You got to just live in the hope and the desire that tomorrow's going to be a better day. And if you can try and figure out what triggers you, then it's going to be a better day because you can do at least something about it. And if you do get sick like I do, you start learning, and even after 22 years of this, I'm still learning what some of my triggers are, what brings it on, how it happens. So anyway, all I can say is hang in there if you're dealing with it. Someone's always got it worse. That's my feeling. And, I guess I'm just an optimist. Glass is always half full with me, that's for sure. Anyway, I hope everybody stays well and have a great day.
Hello and welcome back. Thank you for joining us today for the Norton Educational Series 30th Anniversary Edition. My name is Cecile Rooker. I'm the President and Executive Director of IFFGD. With me today is Dr. William Che from the University of Michigan and Dr. Lin Chang from UCLA. We have just finished a session on nausea and vomiting. And so now we've actually gone through 2 sessions, right, on nausea and vomiting. So we heard from Red Quo earlier, which was Shabani, which was fantastic. And then just now we finished Dr. Venkatesan's presentation on cyclic vomiting syndrome and cannabis hyperemesis syndrome, which is a lot less familiar to people. And had a great patient story on CBS as well. So let me just start with, Dr. Venkatesan talked about cyclic vomiting syndrome, and she talked about cannabis hyperemesis syndrome. They seem very similar, except for the cannabis part. Is there any other difference between the 2 of those?
Not really. I mean, the major distinction is the presence of chronic, oftentimes high-dose cannabis use that defines the presence of cannabinoid hyperemesis syndrome. Otherwise, clinically, they can be indistinguishable. In fact, people have talked about hot showers as a mechanism by which to relieve the intense nausea that these patients experience. And while that is more common, the relief with hot showers, the hot showering activity in cannabinoid hyperemesis syndrome, patients with CVS or cyclic vomiting syndrome can also report the same behavior.
Right.
You know, a lot of times people will use cannabis to actually relieve nausea because it has at lower doses been shown to reduce nausea. But it's not necessary. So when you see a patient like that, you're in a dilemma. Do they have cannabis hyperemesis syndrome, or do they have CVS and they're just using cannabis to relieve their symptoms? But people who have cannabinoid hyperemesis syndrome really are on prolonged high doses for a long period of time, really daily use. And Dr. Venkatesan actually recommends that the way you can differentiate the two is you have to stop cannabis for at least 3 of the cycles of the episodes. So if you have them every month, you have to stop it for at least 4 months to know, does my vomiting stop because I have stopped cannabis? If it hasn't, then then it's probably CVS. So that's one way to differentiate, but otherwise they look very similar.
And remember that cannabis is fat soluble. So it'll stay in the body for a long time, which is exactly why, Lynn made the recommendation that she did. So stopping smoking marijuana for a week or 2 is not an adequate trial to determine whether or not you'll benefit from cessation of smoking or consuming cannabis.
So we've heard a lot about functional dyspepsia and gastroparesis, CVS and CHS. What about other vomiting disorders? So I think that, honestly, there are many people that have nausea and vomiting. And what are some other things that doctors might be looking for? What are some other things to think about?
Well, one differentiation that should be made is whether this is true vomiting, or is this a regurgitation, or we call it could be rumination syndrome. So vomiting is really where you have contraction of your abdominal wall muscles. You're moving, you're bending forward. It's a retching of contents coming out. And regurgitation is more what I think like babies. It's kind of this effortless movement of food and fluid up, and it comes out, you spit it out. Because there is an entity called rumination syndrome, where patients or people will eat and the food doesn't even get into the stomach, comes right back up, and they chew it, it goes back down, and they repeatedly do it. It's called rumination syndrome. And then they'll eventually, spit it out, but that's not really vomiting. But if it's not CVS, then it could be something called functional nausea and vomiting. I'm sure we're going to change the name to chronic nausea and vomiting syndrome. But instead of having these really acute episodes like cyclic vomiting syndrome, like a few times a year, well, in between these episodes, you're feeling okay. Functional nausea and vomiting is really lower intensity, but it's chronic. It's just something that you have almost daily or multiple times. And that is considered one of the functional GI disorders, but it's different than cyclic vomiting syndrome.
So that's something to talk to your healthcare provider about. If it's chronic, even if it's not high intensity, if you're still having that, something to talk to your healthcare provider about.